Well, welcome everybody. My name is Chima Amiaka. This is New Life Christian Centre, and this is a panel discussion pertaining to should we take vaccines for COVID-19? Now, it's a cold Valentine's evening, and I appreciate everybody who's been able to take the time to join us this evening. Please feel free, if possible, to participate by sending questions. I am ably being assisted by our brother Chaz Woods, who will be moderating the questions. We appreciate the need for authentic questioning around this issue. It's an issue that we should be skeptical but not cynical about, and that's something that we can all participate in. So without any further ado, I'm going to introduce the panel who we've assembled for this event. We have Dr. Peter Debrah-Mensah, who's an elder at New Life Christian Centre and also practices as a GP locally within the South London area. We have Dr. Ifeanyi Okike, who's a paediatrician with expertise in infectious diseases, also an honorary member, consultant of Public Health England, and he has experience during his PhD doctoral thesis on working on vaccine trials, particularly around meningitis vaccines for young people and swine flu. So he has quite significant experience in vaccines. We also have Dr. Tosin Ajayi, who's a medical doctor and an NHS and private general practitioner. She has 7 years experience in primary and secondary care. She's also an NHS clinical entrepreneur and has a huge interest in spreading health awareness through her online education platform. So without further ado, what we're going to do is we're going to launch into a series of presentations and discussion. And we've also noted questions that have been provided by members of the fellowship with queries and questions around the vaccine. So the first presentation will be by Dr. Ifeanyi Okike. So without any further ado, COVID-19, the bad, the ugly, and good news. Thank you.
Thank you very much. Thank you for the invitation, and it's so lovely to be here on a special day as well. Could I have the first slides, please? Okay, I think this is quite befitting for today where people celebrate love. Can I move to the next slide? Okay, and I think anyone who's been to New Life will understand the love and care they exhibit, and that's why I say that this is befitting for a day, because sometimes in times like this, you just need someone to care, and New Life has organized it because they care about their members and the community as well. Next slide, please. I do work for these organizations, but I'm speaking today in a personal capacity. Next slide, please. Okay, this is what I have been tasked to cover, and especially to just give information that are based on facts and hopefully address some of the questions at the end. Next slide, please. Okay, so some home truths. We know that COVID-19 started obviously in Wuhan, as far as we know for now, and has been a big problem in nations across the whole world. Now, I've not looked at the data from before, but you all understand. And this bar chart represents the daily new cases in the UK. As you can see, at the peak, it was going up to nearly 70,000 a day. And what I wanted to share in this slide is that you need to think about the publication that came early on in June last year. And in that conversation, there was key characteristics of those who were affected most by COVID. Obviously, COVID infection, it doesn't spare the young, the old, and those who are babies. But the most affected seem to be the elderly, seem to be people who have existing health conditions, and certain occupations that put you at risk, included ones where you met people face to face. And it was also embedded in those most affected, the issue of social deprivation. Now, whilst ethnicity in itself wasn't a risk factor, you can see that ethnicity is embedded in some of these key characteristics, including occupation, including existing health issues. And whilst no one understands why these are the case in terms of ethnicity, it is almost obvious that it is due to the other characteristics above. Next one, please. Now, when we look at London, London seemed to be the epicenter of COVID in the country. And I just wanted to share what is happening since April last year until now. You can see how many people are hospitalized in London hospitals. At the first peak, there were in 4,000. At the second peak, it was close to 8,000. And that is really, really a high number of people in the hospital. And this data only runs till February the 1st. Next slide. Of course, with such a high infection and also with so many people dying, you would expect quite a cumulative number of deaths. So this is looking from October up until the week of 3rd July. Now, every bar and every number simulate humans. They may not be your relatives, they may not be your friends, but these are people created by God who have lost their lives because of COVID. Now, in the analysis from the UK, again, we look at age being a key factor for those who have died, existing health issues being a key factor, again, occupation and social deprivation. And then embedded in that is the ethnicity issue, which again predisposes people to do certain jobs, but also predisposes people to certain health conditions. For example, hypertension and diabetes were key ones in those risk factors. And these numbers have got a very huge cumulative number of people who have been whose deaths have been associated with COVID. It's over 120,000 in the United Kingdom. Next slide, please. Now, if we bring it back to London, of course, some of you will know that not all the deaths occur in hospitals. So the graph above was death in London hospitals, and the one below are those deaths that occurred outside hospitals. Now, if you, again, look at just giving you the first wave and the second wave, how the numbers compare. But if you look in total, again, it's looking at age, looking at health conditions, occupation and social deprivation, with a very high cumulative number of deaths in the United Kingdom, and quite a significant proportion of that were people in London, as you've seen in the graph. Next slide, please. Now, for those who may not appreciate the other types of charts, I just put this one to give you an idea about weekly cases in terms of death in London hospitals, per week, how January became the peak of number of deaths per week in London. And as you can see, this graph clearly demonstrates how big this has been in London. And for everybody's information, in terms of prevalence or in terms of the rate of infection, in all the London GLA boroughs, Croydon itself was only second to one of the Kent boroughs, which tells you that it is a big problem in Croydon. I haven't got the death rate in Croydon, but just because of the number of cases, it's almost transferable that there will be quite significant death in Croydon area. Next slide, please. Now, I bring you the ugly side of COVID. Obviously, for governments across the globe, they had to do something to stop the infection. And one of the ways the infection, I usually say to people that this bug follows people, and that's what the virus does. So quickly there was lockdown, not only in our country, but in other places, schools closed, churches closed. I mean, we became a Zoom church, we became online churches because of lockdown. And you all know the impact of lockdown has been on welfare, health issues, on other friends not meeting together, mental health, and I'm sure one of my colleagues will be talking about this. So, but lockdown had its limitations. Lockdown could not control this infection alone. Lockdown can only just temporarily halt it. And as you saw, as the lockdown was lifted, what happened? We had another wave. In any country where lockdown was lifted, the wave comes in again. More importantly, also, remember those who have gone through this infection and have now seen the other side of the infection. A lot of people are suffering from long COVID, and we still don't know what long COVID will be in the long term. There are clinics set up across the country to deal with this. Now, in every situation, there will be others who will look for opportunity. And I've put this one as logic. So we have a situation here where there are truths and there's some half-truths and there's some fake news. So it is now being the case that during the COVID situation, there has been a lot of theories being thrashed about by so many people. And we have to be careful with that, because such disinformation and misinformation are also creating another form of a viral infection, which we have to be careful and also look for the right information to address. So that is the ugly side of COVID. Next slide, please. Now, the good news is that as a control measure, we've seen that lockdown couldn't do it alone. Having a good hospital system couldn't do it alone. In infectious diseases, we've always had the issue about using vaccines to control diseases. Some of you may have known about polio, smallpox. All those diseases were eradicated because of use of vaccine. Now, in this situation, we have a situation where vaccines have been in development and has been over so many years. And technically, the companies who make these vaccines try new technologies and they upgrade their technology, and they're waiting for a situation where this can be deployed. I do remember when Ebola situation came up, it did not take as long as it normally took for a vaccine for Ebola came up. So for this process, I'm just going to simplify a vaccine development process that usually take a lot of years and also a lot of expertise. So usually for a vaccine to be licensed or to be in use, that vaccine has to be, the technology has to be identified. It has to go through preclinical studies, either using cells or using animals, and then it goes into safety trials where a small number of people will be tested on, and then a larger number of people, and then it is then put into, for the authorities to authorize the vaccine, and then it's put into use, and again, the evaluation of the vaccine continues. This is the standard for vaccine licensure, and this is the standard that the now in use COVID vaccines have gone through. One of the things that people would ask is, are the approved COVID vaccines safe? Yes, they are safe because they have gone through this process and they have come out on the other side showing all safety signals that need to be used. And the other question would be, are the vaccines effective? Yes, they're effective because the onset of the trials, they looked at adults from 18 years of age in most of the vaccines. They used people of Caucasian, Black, Asian. Some of it was done in Brazil, some of it in the US, in South Africa, and in the UK. And they were able to show a reduction in infection. And that's how they showed that it's effective. So for those two questions, it is yes. Do we have a long-term, for example, 10 years experience of this vaccine? Of course, no. But no vaccine goes through the process of having a 10 years safety profile before the vaccine is licensed. I'm not going to speak about the modalities of presenting the vaccine, in the sense that two of the vaccines that we have are made from mRNA, so which is a type of protein that sends a signal and tells the body to produce, just trains the body to produce antibodies against this COVID vaccine. And the other one used a killed virus, and again inserts a protein that would then tell the body to produce antibodies. Technically, these vaccines, all they do is reminding the body and say, well, now you've seen this, the next time you see this particular virus, make antibodies against it to stop infection or to stop a severe disease. Next slide, please. Now, I've kind of shared how these vaccines are made, but then they don't stop there. So the vaccine companies say the vaccine is safe, they're effective. They take it to our own licensing body in the UK is the MHRA. Now in the US is the FDA. In the EU it's a slightly different organization. But all they do is, again, they have a look at the data and they're able to ascertain whether the information given to them is genuine, and they ask them for more information. Once they've done that, which is what has been happening in the UK, then we have another group of professionals, including lay people, not just clinicians, including lay people from all fields, who then look at the data again and say, okay, who should we recommend these vaccines for? And this is done for all vaccines. And the recommendation is as below. That's how they did the priority list. If I take you back to when I told you that people were dying, age was a big factor, health condition was a big factor. Hence, they were able to align our profile and our priority list in the order that has been done 1 to 9. Now, some people are asking, how come this is done really quick and fast? Of course, it's fast because the technology is already existing. Secondly, lots of partnership between companies. BioNTech is a German company, Pfizer is a US company. Funding, the government were willing and able to, because the whole system was in a halt. And we needed something to stop the halt in the system for us to move on as a country and also as a world. And so in a pandemic where other strategies have failed, vaccine has shown over and over again as a means of control of infectious diseases. Next slide, please. Now, some of the other questions that have come up will be, oh, does this vaccine alter your DNA? The answer is no, and the evidence is such because the messenger RNA, the technology that has been used to produce this vaccine, once it gets into your body, that mRNA is destroyed within days. So a few hours to a couple of days, that is gone. So it does not go into your cell, it does not alter your DNA. The other question that comes on quite regularly is, does it make someone infertile? The answer is no. There is nothing in the vaccine that is capable of making someone infertile. I have put examples of things that people really need to think about as potential risk factors for infertility. For example, if you have smoking and drinking, if you have a history of STIs, or if you have obesity. So these are things that these are life-modifying risk factors that we can modify, but this vaccine has no role to play in infertility. And there are other things that people have asked about, side effects. Of course, every vaccine, this is like flu vaccine or other vaccines, if you've received any vaccine, do have side effects, which includes aches and pains and headache and fever and tiredness. They are all transient. And from the safety profile of over the millions of people that have received it, the signal still remains that the vaccine is very safe and it does not cause COVID-19 infection. Next slide, please. Now, how is the uptake globally in terms of the vaccine? I've just put it, but highlighted the UK. I was listening to the news this evening. The UK has actually exceeded 15 million doses as of today. So the slide was prepared a few days ago. And this is really important. And the other thing that is important in the UK is that any vaccine that is in circulation, you still have the ability to report any side effects. We have this yellow card, which the GPs, but also anyone who's received the vaccine has an opportunity to report any side effects. The next slide, please. And just to show you how the dose escalation has been within the UK per week. And that number is rising, like I said, is now 15 million. Next slide, please. And in London, I'm also very pleased to look at the slides showing quite a very good uptake amongst the 70+ year age group. And in fact, it's more than 75%. But there is a but here. The problem is the Royal College of GP have just produced a document which really checks on the ethnicity. I haven't got the data in front of me to show you. However, we know that the people of Caucasian origin are more likely to receive the vaccine than people from other ethnic minorities. And the issues and the answers may be very complex. But why is that the case? So hence some of these seminars and webinars to understand and to ask people to understand this. So just looking at this number, over 75%, it is not universal across all ethnicities. Next slide, please. Now, a lot of countries are very jealous of the UK and they're asking how is the UK successful in doing this? One of the things that we need to understand that in this country, vaccine and vaccine for adults and children is voluntary. You do not force anyone to get vaccine and it's not compulsory, but also it is free. Now, how did the UK come to this point? They procured these vaccines very early on. They believed in the science, but also the people believed in the science. And the NHS has done a mammoth task to get this 15 million doses given. Next slide. Now, to summarize, this is data from the last week, including 12th of February. COVID is still around. Please do not let your guard down saying we don't have any more cases. I've just summarized the cases, daily cases, weekly, and the total in London. London is nearly 20% of all the cases in our country. Next slide, please. But the good news is that we've got a vaccine that millions of people are receiving, not just in the UK, but across the globe, 160 million doses. as at the time I wrote this on the 11th of February. Next slide, please. Now, there is no one strategy for this infection. I would still recommend the best prevention strategy is, obviously, we are Christians. We believe in prayer, the power of prayer. We also believe in the strategy of hands, face, and space, obeying the government guidelines. But also, we have got tools that we can use. The COVID vaccine that has been approved in the UK, the Pfizer vaccine, the Oxford AstraZeneca, the Moderna is going to come very soon. And these vaccines, in combination, we believe it's the best strategy for prevention and control of this disease. That's the end of my talk. Thank you very much.
Thank you, Ifeanyi. That's really kind of you to kind of escape through quite concisely issues around the kind of efficacy and the ethics of the vaccine. We're going to go now to Peter, Dr. Peter Debrah-Mensah. He's an elder at New Life Christian Center. I recall, Peter, when we were discussing this at Oversight, we were quite strict to limit the kind of scope of what we would say as elders to the spiritual, understanding that we're not medical doctors. Obviously, we believe in the sovereignty of God in all affairs, but we didn't want to kind of trespass, as it were. But that's why we put on this event, to kind of understand some of the issues, look at some of the facts, the ethics, which obviously might affect the way we as Christians make decisions. What attitude should we have when it comes to making decisions around something like the vaccine?
I think, first of all, as Christians, we all want to do what is right. We want to please the Master, and that is commendable, and we need to applaud that. And because of that, there will be questions. I mean, and it's good to have questions because you want to do what is right. But we got to think about, is the offer there, the offer being given, something that will be good for us, would please the Lord? It doesn't, because as children of God, we want to please our Master. So I think that's the first goal. That's the bottom line. Is my decision going to please the Lord? And I think that's where people are wavering, because they have been a lot of conspiracy theories that it could be the mark of the beast. And I think none of us want to do the unpardonable sin. So I feel for most Christians that is what they want, to please the Lord, and that is laudable. That should be applauded. And you go to the next step, is that, am I getting the information that will help me make the right decision? And I think we need to go to the right source. I guess there's worldwide there is mistrust of government, and that is what is feeding into the narrative. But you got to go to the right source, get appropriate information, and make a decision. I think we're not here to make a decision for you. We are here as part of the panel to come alongside you, for you to make a decision that you are comfortable with, not to make a decision in fear. The Bible declares that God has not given us a spirit of timidity, but of power, of love, and of sound mind. I even will go to the extent that you don't have to even make the decision based on fear of death itself, because Hebrews 2, 12 and 13 tells us that Christ Jesus took on our nature and he broke the power of death over us. I mean, you could check the scriptures later. So don't make your decision based on fear. And I'll go to a third point. I think you need to, I will say that we are a blessed generation. I think sometimes we do forget. I have been reflecting. I said, I'll go back to 1918 when the Spanish flu came on. I mean, there were Christians like us. I think they did pray, like we are praying, and they were asking for solutions. And unfortunately, they didn't have this vaccine coming up in just a short time. And we should realize that the truth is that because of this knowledge, I mean, for the Spanish flu, for example, it affected over half a billion people, and almost 50 million worldwide died. In UK alone, 228,000 people died. At that point, it was a quarter of the nation, of the population of UK died. So if you're a government with this knowledge, what are you going to do? You got to be proactive. And I think that's what has helped in the production of the vaccine. Money was thrown into the scientists. And what we should realize is that this vaccine, that scientific knowledge in producing the vaccine is not something new. We know the technique already because we've used that for MERS and Ebola. So these scientists needed the money. And what they've done is that there are 78 worldwide pharmaceutical companies and groups trying to bring these vaccines on board, and they are collaborating. So it's not that somebody somewhere trying to produce something to kill all of us. So for me, I think that's what a child of God should do. Go for the facts, because you got to operate on wisdom, and then pray, asking God to give you direction. And finally, I would say that for me, the decision was easier because I experienced this disease. It's such a debilitating disease, which nearly took my life away. So I see this vaccine as a blessing, a quick answer to prayer to help us bring our life back to normal. I mean, look at the enormity of this pandemic. The pain is caused, not only human suffering, but not only physical suffering, but mental suffering. Spiritually, we can't even go to church. Socially, we can't see our loved ones. Economically, it's affecting everyone. So this is what we are facing. And as a child of God, we've prayed, and I feel that that is one of the answers, if it's not the answers to this problem. So I go along that line. I won't say that I'm forcing you to take the vaccine, but you sit down, make that analysis, and then ask the Holy Spirit to help you to make an informed decision.
Yeah, thank you, Peter. So just to put a full stop on what you've just said, is that basically each of us should look at the facts, try to determine what the information is, or the data, good data is, good sources of data, then speak to our clinician or our doctor, and then make a kind of informed decision as to our own particular circumstances. Because everybody, particularly within a fellowship of the size of New Life, will be of different in different situations. But that's quite helpful, Peter, and kind of explain what's it been like being a GP in this time. What's it been like, kind of operating as a GP?
Well, it's been challenging because I mean the normal way of operation has changed a bit. I mean, most of our patients, we do virtual clinics, either telephone consultation or video consultation. So sometimes you're wondering whether you're making the right decisions, but then we also do see people face to face. The service is ongoing. What we should realize that despite COVID, other diseases are still ongoing. We still have heart attacks. We still have people with strokes. We still have people with ongoing diabetes, blood pressure, cancer. So when you're unwell, please, your GP is available. We are not only shut down for COVID. So if you need a doctor, please do contact the doctor. The surgeries are open.
That's good advice. Thank you for that, Peter. We're now going to move on to Dr. Tosin Shitoba, who's going to come and deliver a presentation for us. Boma, can you please put up a presentation, please? Thank you. Now, Tosin, you're muted.
I am.
It's always a pleasure, Tosin. Go on.
All right. Thank you very much. And thank you for having me. It's so great to see so many people here today. And I think that just echoes the importance of having something like this, and that people are looking for information and people are looking for answers. So I'm going to continue the discussion, and I'm going to be talking about some common topics and some common themes when it comes to COVID-19 and especially the vaccination. So let's go on to the next slide. So we thought it would be important to discuss the real difficulties and challenges that people have faced during this time. In terms of public mental health issues, the main psychological impacts we've seen in the data is elevated levels of stress and anxiety. So it's really, really having a big impact on people. And it's pretty normal for us to have all felt something in this period. Sometimes in life we have changes that hit us at different times in our life. But however, in this period, we've had multiple changes thrown at us at once, from the loss of loved ones to stress at work or losing your job or difficulties finding work, to some people being unwell themselves or just the fear of the unknown. So I think it's important as a community and as a church that we feel comfortable in talking about our issues and supporting each other in this time as well. Move on to the next slide. So I thought it would be useful to quickly go through some tips of coping through stress in this time. I'm not sure if the slide is readable from where you are, but I think as Christians and children of God, we can lean on the word of the Lord and the Holy Spirit in this time, which is great. But it doesn't mean that we're immune from the struggles of the world and day-to-day life. So just to go through some of the topics here, this was taken from the World Health Organization website. But first of all, like I said, it's completely normal to feel some kind of emotion at this time. And I think recognizing that in yourself is important as well at this time. Now, be aware that not everything being said about COVID is accurate. And I'm going to touch on this a little bit more later on. I think it's really important that we are not inciting fear, not only in ourselves, but in others as well, with the information that we're reading and the information that we're spreading. Limit your stress and fear. Easier said than done, I would say, but things such as watching the news or even the people that you talk to and surround yourself with, are they uplifting you? Are they making you feel good in this time? Are they giving you information that you feel is reliable? So kind of make sure your environment and your day-to-day life isn't constantly making you feel stressed and making you feel fearful. Do things that you've done in the past. I think we've all had coping mechanisms that we can rely on in the past. That might be something so simple as taking a walk, exercising, talking to a friend or family member. And I think suddenly during this pandemic, those kind of coping mechanisms were suddenly taken away from us. But I think be intentional in this time about still incorporating those coping mechanisms into your day-to-day life. So doing a workout at home or picking up that phone, speaking to a family member, speaking to a friend, and being intentional about using those coping mechanisms in this time. And if you're staying at home, just being active, making sure you're eating well, being active, those little tiny things can really make a difference in your day-to-day life. And dealing with your emotions in a healthy way. Like I said, it's really important that we recognize when we need help, and as a community that we're supporting each other in this time. So next slide, please. Supporting each other. You don't have to be a mental health professional or a doctor to support someone that is going through a difficult time. And like I said, as children of God, we should be wanting to support each other. We should be wanting to be there for people who are in need in this time. So some simple things you can do, checking on each other. Very simple, pick up the phone. Like I said, be intentional about reaching out to those in the church that maybe you have not heard from or you haven't seen in a long time. listen and reflect. It sounds so easy, but sometimes it's difficult to do. Sometimes it's difficult to just listen. Sometimes people don't need advice. Sometimes they just need a listening and a kind ear. And also ask questions. If you're concerned about someone, ask them, how are they feeling? Ask them, how are they doing? And if you're still concerned, ask again. So next slide, please. So support, where can we get support? I think number one, I hope that you all know that the pastoral team at New Life Christian Centre are there for you if you need support, and you shouldn't hesitate to reach out and contact someone. And again, even though we are not physically in the church right now, we are a church family, you're a church community. So reach out to people in the church. If you have a connect group or outside of the church, friends and family, like I said, we have to be intentional in this time to actually really try and stay connected with people. And if you feel like you're struggling, in any shape or form or with your mental health, then please do know that you can go and see your GP. That is what we're there for. We're there to help you. And I've put some resources up on there for different organizations and charities that support people with different mental health issues or different struggles, all the way from anxiety to bereavement to younger children and teenagers going through a difficult time. And also pregnancy. So Tommy's is up on there, and that's a really good resource for people that are pregnant in this time, because it is a difficult time to be pregnant in. And that leads me on to my next discussion. So next slide, thank you. So like I said, it's difficult in this time, I think, pregnancy. Pregnancy is difficult in the most normal of times, but when you throw a new virus or pandemic into the mix, I think it can be a difficult time. And there's lots of questions around pregnancy and the vaccine, and understandably so. So I wanted to address some of those common questions that I've seen and heard going around. So first of all, can pregnant women receive the vaccine? Now, just to highlight, this is the current guidance as of when I did these slides, which was yesterday, but also as of today. So this is the current guidance. And I say that because guidance is constantly changing. And I think we've seen that in the past year, that as we learn more, as more scientific information is coming out, we know more about the vaccine and we're getting new and new guidance. So just be aware that this could change. But at the moment, the latest advice is that 2 groups of people and women who are pregnant can receive the vaccine. So those are people who are at high risk, so clinically extremely vulnerable, and those people should know who they are by this time. But if you don't, the government website or the NHS UK website both have lists, so you can look on there. Or people that are in jobs that put them at risk. So those are health or social care workers. Now, why is this? Why has it been limited to these 2 groups? So this is essentially because the vaccine hasn't been tested in pregnant women as of yet. So routinely, we can never say that vaccines are safe before they've been tested in certain groups. However, the testing on the vaccine so far, we do know that it has passed all safety standards. However, we just can't say it's available at the moment for all women who are pregnant. Now, does this mean that the vaccine is not safe in pregnancy? No, not necessarily. We use lots of vaccines in pregnancy, such as the flu vaccine and the whooping cough vaccine. And very similarly, the COVID vaccines we're using at the moment, they're not live forms of the vaccine. So unlikely to cause any harm, but as I've said, we can't say that it's available for everyone at this moment because they just haven't done the studies as of yet. However, the non-clinical research that they have done in both the Pfizer and the AstraZeneca vaccine have shown that it's thought to be safe in pregnancy. So we're getting there. And then how about breastfeeding? So they recommended that the vaccine can be received whilst breastfeeding, and it's not shown to be harmful. Again, it hasn't been directly tested in women who are breastfeeding, but they've weighed out the positives for women that are breastfeeding against which they think are very, very low risks of the vaccine during breastfeeding. So move on to the next slide, please. So what does this mean for you? So like I said, if you're currently pregnant, you will only be offered the vaccine if you're at high risk. Now, if you've had your first dose and then you become pregnant and you're not in one of those high-risk groups, then the advice at the moment is to wait until after your pregnancy, so after you've given birth, to receive the second dose. Women who are trying to become pregnant, you don't need to avoid pregnancy after having the vaccine. There's a lot of talk on fertility and if the vaccine affects fertility, and there's no founded cause of concern with the vaccine and fertility. Now, always discuss your options with your doctor. I think with anything in healthcare, it's all about weighing out your options and balancing your options and the risks and the benefits. So always discuss your options with your doctor, nurse, or midwife. And then ask yourself, do you feel comfortable with the information you have? I think it's always important that no matter how much information you're given, even if it's from reliable sources, you have to feel comfortable with that information you have, and you have to feel comfortable with the decisions that you're making. And remember, the choice is yours. Next slide, please. So misinformation. Fake news can spread like a virus. I think if I had everyone in front of me and I asked them hands up if you've received a WhatsApp message in the past year that seems pretty crazy to you in terms of COVID, you would probably put your hands up, because information is just spreading so fast and fake information is spreading so fast. So what can we do about it? I think some tips. So number one, first of all, assess the source. Where did that information come from? Do you know where the information came from? Who wrote the information? When it was written? And very likely, if you're receiving something through social media or on WhatsApp, very likely that you actually don't know who wrote that information. So be careful about the information that you receive and go to trusted websites and trusted domains. How much do you yourself know about the topic? Reflect on your own boundaries. And as we were saying before, you have your own wisdom, but lean on God for wisdom as well. So reflect on your own knowledge and seek wisdom from God. Look beyond the first results on search engines. Often the way search engines work, they work with what's most popular, and that's not always what's most accurate. So just be careful and think before you share. We want to make sure that we're sharing correct information. We want to make sure that not only are we looking after ourselves, but we're looking after others. That's our family and friends. So sharing information that we don't know to be true or to be fact could be potentially harming others. So think before you share. Next slide, please. And this is just a slide to say that you can report any misinformation that you see or that you're not sure about. And if you go onto the World Health Organization, it has a really good page where you can just click on each link and it shows you directly how to report any misinformation. Next slide, please. And just some reliable sources. So hopefully you all know by now that the government website and the NHS website are your two go-to places when it comes to information, current and up-to-date information on coronavirus and the vaccine. And then obviously we have the news. Also take the news with a pinch of salt, I would say, especially if you're watching and taking information from news resources that are global, because they're not always relevant to the UK and what we're practicing in the UK at the moment. And then I've just included there the Royal College of Obstetricians and Gynecologists, because if you're pregnant at this time or you're considering pregnancy, they have up-to-date information on COVID and the vaccine and when it relates to pregnancy. So that's it from me. Thank you.
Tosin, that was really good. Thank you very much for that. That was really insightful. We're now going to move on to kind of addressing some of the questions that we've received during the course of the last 2 weeks. What I'm going to do is I'm going to bring up some of the questions. We've got some questions on a Q&A function on Zoom. We've also got some in the chat. We also got some sent questions. So what I'm going to do, I'm going to read out the questions and I'm going to kind of divvy them out to our esteemed panel. So the first one, and forgive me if you've touched on some of these answers in your presentations, but we'll just go through them. So please, can you tell me if a vaccination will be given every year? Peter, you're a GP. you're involved in that type of work?
Okay. At the moment, I would say we do not know. This vaccine just came in. This virus is a new virus. We just know about this virus for the last, I would say, 30 to 40 months. And what we do know is that in a natural infection, it looks like the antibody you produce tend to wait over a period of 3 to 6 months. Even for that, we also do know that though your antibody wanes, your T cell or your T memory cells are still there to prime you when you exposed to that infection. Research is still ongoing to see whether this vaccine, the antibodies we produce, will last long. So that we'll have an idea maybe in about a year's time to know whether the immunity that we get from the vaccine actually is permanent, or like the flu, we need to have a booster every year. So we do not know the answer.
Okay, thank you very much for that. Another question has come from Brother Bill. I'm prone to anaphylaxis. Which vaccine is best for me? And I'll address that to Tosin.
Yes, good question. So when it comes to anaphylaxis, which is basically a severe allergic reaction, we are currently recommending that you do not take the Pfizer vaccine. So that's if you have an anaphylactic reaction to lots of medications, or you have an anaphylactic reaction to something that's in the vaccine, or you haven't had an anaphylactic reaction, but you're not sure what it was to. So basically not the Pfizer vaccine, but currently you can take the AstraZeneca vaccine.
Thank you for that. This one I'm going to address to Dr. Ifeanyi. This has come from somebody who's saying COVID vaccines are new technology. Is the study finished, or is there still testing to be done with these vaccines as they're being rolled out?
Okay, now that's a very, very good question. The mRNA technology is not a new technology. It's a technology that is relatively newer than the old vaccine system. So the old systems was you kill a virus or you kill a bacteria and you use it to prime the body to make antibodies later on. That technology has advanced in the sense that we are now going under the bacteria. For example, the meningococcal group B vaccine is an example of revolutionary technology. And that took 20 years because the technology was so slow. Now, when it comes to mRNA vaccines, the mRNA technology has been there a long time. In fact, in cancer treatment, mRNA is really very potent and is really advancing the care for cancer patients. So the other thing to say about technology is also that the Oxford AstraZeneca didn't use the mRNA, used the killed virus, but then inserted a protein into it. Again, these are technology that is already in existence, but it just needed to be sped up in a way that we can now actually look back. This technology is probably going to be applied to everything we know about other vaccines. Can you see the scale of production, the scale of standardization, and scale of distribution? Because these technology are very unique. You can use them. You can even set up a plant, a tent in Croydon, and produce the vaccine that is being produced in Moderna somewhere in Italy, or Pfizer somewhere in Germany, because it's a very smooth and streamlined technology. So from that point of view, it's not new. It's just been applied in a rapid scale. Now, in terms of the studies, the companies have done enough studies with enough safety profile, with enough to show the effectiveness or the efficacy of the vaccine that convinced the licensing organization, not just in America, in Europe and in the UK. Of course, for every vaccine, it doesn't stop at licensure. So this is emergency use because that's the situation in a pandemic situation. There is post-marketing evaluation that is ongoing. For example, there are studies starting in children now. They're going to look at safety data after 2 years. They're going to look at safety data after. So the data will continue to come, but that is also in line with the use of the vaccine. Any vaccine is as good as when you use it. Okay, so actually, this is the best test. The best test of a vaccine is actually when you use it because it's in a larger scale. And so far, 160 million, as opposed to only 40,000 and 60,000 in the studies, has shown a very good safety profile. And I think it's a good thing that we continue to monitor and follow what's happening with the vaccines. Can only be a good thing.
Thank you very much for that. Circling back to one of the issues that you touched in terms of ethics in your presentation, Dr. Ifeanyi, a number of people have submitted questions pertaining to the use of cell lines and the ethical issues relating to whether fetal material has been used from abortions, and this has been included in the development of any of these vaccines. So can you kind of touch on that issue, and what is the relationship between fetal matter and these vaccines, and if Christians have particular concerns around whether they should take a vaccine based on that kind of development, the use of that material in that development, what's the information there that we should be aware of?
Right. Thank you very much. Thanks. That's a very good question, and one that has been of particular concern amongst Christians, not just Pentecostal, evangelicals, Catholics. And can I just say that this is not an issue that's only arisen because of COVID-19. This has been a long-standing question that people have answered over many years. The first thing to say is that the current vaccines that we have, as far as I have delved into and looked at, that there is no fetal material that is contained in the vaccines that we have. Now, some of the companies have put out that in the development of their vaccine, there are stages in the production where these vaccines are in the preclinical studies because they had to grow, they have to do stuff in cells. So in the sense that the vaccine in development has to pass through fetal cells, which are rapidly developing cells. I'll come back to where those cells come from. As far as we know, what I have seen, that the Pfizer and Moderna didn't go through this process because of the type of technology that has been used. Now, the thing to say about fetal cells, for Christians, this has been very controversial matter. What the history, if you want to, I mean, people can read it, and I can only summarize it for this webinar, that in the early 60s, 70s, there were two fetuses that were legally, in those days, legally aborted electively. And cells from then were used and multiplied in the sense that these fetal cells are pluripotent and they can produce rapidly. And they have been used in research. And this is now multi-generations after those cells were harvested. And no new cells or no new aborted fetuses have been used in those cell line development. So the reason they use that in other vaccine development has been that the viruses had to grow in cells. And we're talking about other vaccine trials, have to grow in cells, and then before they're tested in animals and then into humans. So the issue will be of a personal conversation with yourself or your pastor about what you think about what has happened legally in the 60s and 70s. And those particular cells are no longer, generations after they were harvested, being used in other research. And I don't know the extent that people value, what has happened in that time. But what I do know is that there is no active harvesting of fetuses in order to produce vaccines. And I can also summarize by saying that the current vaccines, we've been told and I've read that the Pfizer and the Moderna, because of the RNA technology, has not passed through that process of the HEK, or the code name that's being used for this fetal cell lines. It's a matter of principle and of the heart, really. If you're thinking that we are in a situation whereby for medical equipment or medical tests to be done on animals or humans first, they do it on rapidly dividing cells before they get to human. And these cells have no active role in promoting abortion. And abortion is an issue for Christians, which as Christians, we can have opinion about it at an appropriate time. But with these vaccines, it doesn't quite sit, because it's not actually, this vaccine doesn't promote abortion per se in itself. But I just have to highlight that in historical development of vaccine, there has been usage and people of authority, both from Christians and even the last Pope before the current one has made a statement about this and recommended it to people of his church. So I don't know what the individual belief and convictions are, but we are in a situation whereby this medication has been produced in what seems very ethical and for use to prevent further death and suffering. And we know that Christ said he came that we may have life and have it in abundance. So this is a source and a way of bringing life to more humans, and the pain and suffering that we have gone through COVID is probably a good use of our technology to produce these vaccines.
Okay, thank you very much for that answer, Dr. Ifeanyi. Okay, the next question I have, and I will send this one to Dr. Peter. If I've had illness twice from flu vaccine, which COVID vaccine should I have? So the person's had illness twice, I think from having the flu vaccine, maybe an adverse reaction to having the jab flu seasonally. And then which COVID vaccine do you think they should have? How should they go about making that decision?
All right. Okay. I don't think I can recommend any specific vaccine, but what you need to do is when you're invited, you're always asked to give your medical history, and also allergies are taken. So you should inform the person going to give you the injection that you have reacted to flu vaccine, and then the necessary precautions can be taken. I mean, so far, what has been said is that if it's not anaphylactic reaction to any of the ingredient of the vaccine, then that shouldn't bar you from taking the vaccine.
Another question, and I'll address this to Dr. Tosin. Approximately what percentage of vaccine recipients have had aggressively adverse reaction to the vaccine, and how does it compare with other vaccination types widely used in the general population? So to what percentage do we have any kind of understanding at the moment from the data as to aggressively adverse reactions? I suppose aggressively adverse reactions is dying on it. But yeah, I mean, we heard of what happened in, is it Norway? Or
yeah, it's Norway that.
Yeah. So 26 people. It was elderly people within a care home setting. I'm not sure, but do we have any information on that at the moment, Dr. Tosin?
I don't have particular statistics on numbers on severe or bad adverse reactions or possible deaths. What I will say is the large majority of people that have had the vaccine, it has been safe in. And if there are going to be any possible side effects, they're usually mild, and you'll usually have them for possibly a few days after. And that's not because the virus is in your body. It's not because the virus is live, because none of the vaccines that we're having or being given at the moment, the vaccines aren't live. It's usually because your body's kind of kicked in this immune response. So sometimes when you feel a little bit tired afterwards, or you might feel a little bit achy, mild, possible kind of flu-like symptoms, it's because your immune system is building up all those antibodies in your body.
Thank you very much.
One
question. Cool.
Something. I think there were two nurses who reacted to the vaccine with anaphylactic shock, and I think it was WhatsApp, and everybody was talking about. Apparently, those two nurses actually had history of anaphylaxis. However, because of their risk, they were so keen to have the vaccine that they didn't report it. But fortunately, they were all having an EpiPen, and that was reversed quickly.
Okay, thank you very much for that.
Can I just add, Chima, although these anaphylaxis have happened, they are similar to what is expected per million in overall vaccines that we have in circulation. The CDC produced data on all the anaphylaxis that happened in the US, and they were exactly the profile of people that you would expect. So a lot of them, like Dr. Peter has just said, had a history of allergic reactions and anaphylaxis, but no deaths from those anaphylaxis that they recorded up to January that they've analyzed quite carefully.
Excellent, thank you. Well, let me dive into the question and answer function. Okay, let me see what we've got here. When will the vaccine be available to everybody else? I believe that they mentioned that they met a target today of 15 million, and I think that's four cohorts of people have been sorted out with at least the first vaccine. Do we have any indication as to when will the vaccines be available for the rest of the population? And I'll address that to Tosin, Dr. Tosin.
I was going to say I'm not sure.
Okay.
So it's hard for the others.
Dr. Peter?
The first speaker has got the table on the chart. I think they're planning that by end of May, everyone would have had up to age 40 and above would have had their vaccine. Everyone will get information either from NHS direct or from their GP anyway.
Okay, cool.
And I think just to add, just last week, if you are over 70 and you haven't had your vaccine, you can opt in to have your vaccine at this moment. So before it was people that were being invited, but now if you're over 70 and you haven't been contacted, please contact your GP if you do want that.
Excellent. Okay, this is quite a long question, so bear with me. Would a person who has hypertension and asthma be considered a high risk for coronavirus, clinically extremely vulnerable, and automatically eligible for vaccination now, or do they have to bring confirmation from their doctor? Key workers have received the vaccination, have been told which vaccine they have received. I read somewhere that people will not be told what vaccine they received, or is this incorrect? And if so, can you ask for a particular vaccine, and which vaccine would be best for someone with hypertension and asthma who suffers the usual side effects to vaccines? So I think there's a few questions in there. One, what is the best type of medicine if you have hypertension and asthma? And do you get a choice actually in which vaccine you're offered, or is it kind of whatever comes along the conveyor belt first? So I'll go to Dr. Ifeanyi for the conveyor belt question about choice, and specifically hypertension and asthma to Dr. Peter. Go on.
All right, thanks. A very good question, and really important that people ask questions pertinent to them, because at the end of the day, these are decisions that are made at a personal level, not corporately. The first thing to say is that there is no vaccine that is specially made for people with hypertension or asthma. So both vaccines are licensed to be used by people of adults who have the age group that has been given the vaccine, that have these rather illnesses that are deemed as high risk, because hypertension and asthma were in the class of those who had severe form of COVID. Now, the other question about whether you can choose which vaccine to have. Well, we are lucky in this country that we have a choice of 2 vaccines. However, the locations or the hubs that give the vaccine, I'm afraid, do not have a choice. For example, if you're going to give the vaccine to someone in a care home, the one that comes out of -70 degrees may be a bit more difficult to transport compared to one that is about 2 degrees. You need the 2 to 6 degrees. So this affects the location. The location really has an influence on which vaccine you receive. And there are some hubs that are specifically tagged Pfizer vaccine hub, and some are tagged the AstraZeneca hub. So I think when you go to your center, they will tell you what is available. They will discuss the vaccine with you, and the choice ultimately is yours at the end of the day. And the last bit, I just take it. It's not a secret. You'll be told, and your card would say exactly which vaccine you've received, and your GP will be notified of the vaccine you've received. It is not a secret. You will know. You don't really have a choice when you get there. I don't know what other centers are doing. When I went for mine, I was just told we have the Pfizer, and the discussion went on. And I said, yes, thank you very much. I'm happy to receive it. And then I received it, and they gave me the card. Okay. Does that answer that first part?
Yeah, I think that part. I mean, Dr. Peter, there was a specific element within that question pertaining to hypertension and asthma, but I suspect what Dr. Ifeanyi said kind of covers that. Do you have anything to add to that?
Unfortunately, I mean, the groupings have already been done from NHS England. However, GPs can review your records and decide whether you are more at risk. I mean, it's not just hypertension and just asthma, because somebody can have hypertension, which is well controlled, and can also have asthma, which is well controlled. However, there are a few group of people who would have, for example, I've got a patient who was not due, have uncontrolled diabetes, and those are at high risk. So the GP could escalate that so that you move up above the group. So it's not just merely asthma and hypertension. If you feel your asthma and hypertension is poorly controlled, then please see your GP about it.
Okay. One question, and I'm going to fire this one to Dr. Tosin, and this is kind of relates to what you said about information sources. On the website www.vayers.hsss.gov, people are reporting deaths about COVID vaccine. Why you and the public don't know about those reported deaths?
I didn't quite catch the full website, but
I apologize. So basically what the person's saying is that there's a website where people are reporting about COVID vaccine, but it doesn't seem to be getting much airing in, or it doesn't seem to have the credence attached to it that other sources that you mentioned have. So could you kind of speak into that kind of?
I would say, without saying if the source is reliable or not, because I don't know the source. I think it's really important that we focus on the information that the government is collecting. And as far as we know, we have those possible deaths that were mentioned before. But again, reliable sources of information, it's unclear if that's a reliable source of information. And also, deaths do happen. So, you know, sometimes people can make a link by themselves of whether it possibly a vaccine and a death. But if the link isn't proven, then that's not the information that we are receiving, if that makes sense.
Excellent. And just as the by and by, if it is a government website, it generally would be .gov.uk. And so, as you said earlier, one really has to be careful about where you get information from, because all information has a dynamic behind it, and it might not be in your best interests if it's not accurate. So always be very careful, very carefully where you get your information from. Okay, let me go into the chat, see if there's any questions in there. Okay, let me see. I felt extremely unwell in the last two occasions, 2013, 2014. I took seasonal flu vaccine. As such, I stopped taking the flu vaccines. How am I sure that this COVID-19 vaccine would be different and not make me feel unwell like the others I've taken in the past? Could it be that I have undetected underlying health conditions that could be causing adverse reactions to vaccines? I'll address that one to Dr. Peter. So this person had adverse reactions to seasonal flu vaccines in 2013 and 2014, and they feel that they may have some undiagnosed adverse reaction to vaccines. So how can they be sure, or is that something that they can't be sure about?
It's quite difficult to tell. I mean, what ingredients is in the flu vaccine that the person is allergic to. I mean, if you start concerned, then it might need to go to the GP to refer to the allergy clinic. If that allergic response is severe, not maybe just itching or swelling, but if you haven't swelling of the lips, difficulty breathing, that is quite a severe allergic form, and probably will need a referral to the allergy clinic for them to assess specifically what ingredients in the flu jab the person is reacting to. But I mean, what is in the flu jab is not the same as what is in the COVID vaccine. So what the person needs to do is to report it to whatever clinic is sent to. It's not a contraindication. What might happen is that if the center feels that they can provide the appropriate measures to protect that person, you might be sent to a hospital center where they have all the equipment ready in case you do have an anaphylactic reaction.
Okay. There's another question. My daughter suffered from Stevens-Johnson syndrome. Can she receive any of the vaccinations?
How old is the person, please?
Knowing the lady who sent it, the daughter would probably late teens, early 20s.
Okay, I mean, Stevenson-Johnson is a severe form of an allergic reaction, but it will be specific to a certain chemical, or I don't know, antibiotic or a medication. And that particular ingredient might not be in the vaccine. So I don't think it is, it will prevent her from having it. However, once she reports, she needs to let them know so that if the center feels that they are not confident to give the jab, then she'll be sent to the appropriate place where they have resources in case there is a reaction.
Thank you very much for that. I'll just survey some of these questions in the chat, question and answer. I don't know if this is really answerable because I don't know whether you received or looked at any of these studies, but regarding Dr. Tess Laurie and her studies on ivermectin, do you agree or disagree with her findings that this medicine works to cure COVID-19? I have no clue whatsoever as to that study, but I'm going to send that to Dr. Ifeanyi. Go on.
You're asking me. Okay. So ivermectin is a medicine that is used to treat parasites. Of course, there are trials that have shown its efficacy in treating patients with COVID. And that trial is laudable and really good. However, I put however, because the UK recovery trial is the biggest trial in the whole world regarding COVID. And we have shown very cheap medicine that works, dexamethasone, but also another medicine that is slightly expensive, tocilizumab, which works as well. And that's the most recent drug that's been shown in the UK. So I would trust the recovery trial because the UK practice is based on the recovery trial, which again showed the dexamethasone and shown this other medication I mentioned earlier. I mean, obviously, if you live in a country where ivermectin has been recommended and is in use, I wouldn't say don't use it. But if you are admitted in a UK hospital, I think you're more likely to receive dexamethasone and tocilizumab, which again have been shown to reduce death and also reduce the length of stay in an intensive care situation.
Thank you very much. In terms of the groups that were tested in trial phases for these vaccines, which groups were underrepresented or not tested at all? I know that obviously up until quite recently, I mean, they mentioned today that they're going to start testing 6 to 15-year-olds or so, or 18-year-olds, sorry, do trials on them. But which groups were not tested when it came to the kind of development of these vaccines? Dr. Tosin, do you have any answers?
The vaccines, the 2 vaccines that we're currently using in the UK, they were tested on a wide range of people. So different ethnicities, Black, Asian, people from South Africa and Brazil, all around the world. So we know that it was tested on various peoples and with different comorbidities, so different underlying health conditions. So I can't say, apart from children and pregnant women, it doesn't spring to mind one particular large group of people that were left out in the testing process of the vaccines that we're using.
Okay, thank you. One question's come about the actual big pharma who have produced these products. Vaccine makers cannot quarantine safely by offering compensation if they have side effects. Why is it that they have got indemnities from the government, basically, against people suing them if they suffer adverse side effects? Why do you think that that might be the case? Is it normally the case, or is it something particular to these times that we're in and the kind of speed of which the government threw money at them and so on and so forth? So I'll address that to Dr. Ifeanyi.
That's rather slightly political question as well, but there's some scientific basis to it. I think it's really very difficult and sometimes very hard to look at what happens between government and farmers in terms of procurement and the processes they have to go through. Now, we have to remember that at the offset, nobody knew how this virus was going to behave. Some scientists knew how the virus was going to behave. What we did know that the companies were already with existing technology, they were able to plan and program and say, okay, if we are given the right finances and the support, this is what we were able to do and develop a vaccine. And of course, you cannot develop a vaccine without money. It needs money. But even if you develop a vaccine, you need people to test that vaccine. And I have worked in that level where I'm the one preaching about a vaccine under clinical trials to people, not just adults, children. Now, in this instance, it seems to me that at the early stages, UK government were one of the ones that went really early to the companies and say, you know what, we believe in the science. We know that you can do this. So they had these negotiations about what they're going to do, how they're going to protect them, finances and all those kind of things, and partnership as well. You can see BioNTech was a very small company, joined up with Pfizer. AstraZeneca joined up with Oxford. So in that process, I suppose they had to put some legal backgrounds for themselves in terms of a company. But in terms of safety, the MHRA has said that there was no compromise in the process of licensure or giving emergency use. Remember, this is emergency use authorization. This is quite different to an approval, which is not in a pandemic situation. So that could be the legal framework for which this is done. And remember, this is not the case from before. I think it was after the 9/11 that the FDA came up with this emergency authorization so that things can be sped up and used in an emergency pandemic or health situation. So it is a new phenomenon, and that's been since 9/11, 2001, and this came up with the FDA in 2004. I don't know the legal text that the government and the companies came in terms of agreement of indemnity and insurance. But what I know is that in terms of safety, there was no compromise by either the EU, the FDA, or by our own MHRA. And I think the vaccine also speaks for itself in terms of what we have seen so far in the 160 million doses that is recorded as at 11th of February in terms of profile. So whilst I don't know the details, I could, we could look into it with MHRA and then put some text in the chat sometime in the future. That would be my short answer to this.
Thank you very much. Thank you very much for that. Next question. If I've had COVID infection recently and was asymptomatic, do I need to be vaccinated, assuming that I have antibodies present? Dr. Tosin.
Essentially, the advice is yes, that you should still be vaccinated. We do think that when you have the vaccine, your body builds up some form of natural immunity and some form of antibodies, but we don't know how long they last. We don't know actually their benefits in terms of fighting off another possible contraction of COVID. So we don't know the natural antibodies response, but obviously we do know the response from these vaccines. So essentially, yes, you should be vaccinated if you want to, and if you've had the virus before. That's the advice at the moment.
Okay, and another question that was posed is, why in Africa has there been a perception of there being less COVID deaths? I'm going to go to Dr. Debrah-Mensah for that one. Doctor, you're muted. You're muted. Peter, you're muted. Sorry.
Yes, I'm back on. Okay. I think information coming from Africa. I mean, for example, we do know about the deaths in South Africa. I mean, comparative to Western Europe, it looks like the figures there are low. There is a theory, we fully don't understand, that probably people in Africa might have been exposed to other coronaviruses. So building some form of immunity, which probably is protecting them against this particular coronavirus. That is a theory going on. We fully don't understand. I mean, they were suggesting like vitamin D levels, which unfortunately this has been disproved because there are other areas in the tropics, and other areas like Mexico, where they are also in the sun, Iran and other places, Pakistan, who are having high rates. So we can not contribute to vitamin D level. But suddenly some African countries who had low deaths, unfortunately, there is a spike. So we have to wait patiently to see how things unfold in the next few months.
Okay, so Dr. Tosin, I think somebody wants to kind of re-emphasize, are there any side effects for pregnant women that are known at this time?
So in terms of pregnant women taking the vaccine, we don't know as of yet. Generally, when we give non-live vaccines in pregnancy from vaccines that we've used in the past, they're generally safe. But this vaccine hasn't been tested in pregnant women. So at the moment, what we're saying is we have to weigh up the risks / the benefits. So pregnant women are already in the high risk group for possibly having a worse experience when it comes to having the virus. So essentially, I think it's individual, and I think every woman who's pregnant or considering getting pregnant at this time should speak to their healthcare professional, and especially if you have any underlying health conditions. But at the moment, we don't know if there's any side effects with the vaccine. But from the non-clinical trials, it's considered to be safe, but we just haven't done the clinical trials yet. That makes sense.
I think your mother in the chat has kindly cleared up some information that we were talking about with respect to there's hhs.gov, which is an American site for reporting adverse reactions to vaccines. A UK equivalent is the yellow card for reporting adverse events to drugs and vaccines, which is yellowcard.mhra.gov.uk. So all of the information that we have here will be placed on resources after this meeting on New Life social media platform. So don't worry about it if you don't get any of the information. Also, we're going to place on the record the presentations which have kindly been given by Dr. Ifeanyi and Dr. Tosin. So don't worry about that. Another question, what about the ethical issues with the company Pfizer, as they have committed human rights violations in the past, e.g., in Nigeria when they had to pay 108,000 to families in Nigeria for illegally testing on children? I'm going to shift that one to Dr. Ifeanyi.
I have to do a disclaimer. I have no share in Pfizer. and it is quite good that when people do bad things, that they're caught out and they pay for it and they have to say sorry or do whatever it takes. I mean, Harold Shipman is a doctor, is a GP who behaved quite badly. Doesn't mean that all GPs are bad people, or doctors, for example. Now, yes, I mean, people will even say Tuskegee in the past. There are things that have happened. I mean, there are things that are happening now as well. I mean, don't get me wrong. I see in my own day-to-day life where there is disparity in how people are treated because of who they are, what they look like, and all those things. But that is outside the sphere of this conversation. There is nothing that we can see with what Pfizer has done with the vaccine so far that we can see that suggests that there are, for example, microchips, or for example, the vaccine controls different skin color if it goes into that. Yes, what they've done in Nigeria was bad. They were cut out and they had to pay for it. And I think it was very right. Other companies, there are companies that have made other medications that the signals were there, but were not taken and were ignored. And then those companies eventually had to pay for it. But we shouldn't use that and extrapolate to everything else. When this pandemic came and it was obvious that it was disproportionately affecting different groups of people, that was called out, and there was kind of a semi-inquiry trying to understand, and that understanding helped in trying to put things in place. So I like I said, I don't have shares in Pfizer, and I do think that in terms of the vaccine, that BioNTech and Pfizer and AstraZeneca and Oxford, Moderna, and the vaccines that are licensed for the use in the UK, actually what we're hearing is not for profit. For example, the AstraZeneca one, it's not made for profit, and it's for trying to use it to help the other parts of the world where actually we're talking about acceptance here. We have places where they haven't even seen one dose of vaccine near them, first of all. So I honestly would say bad thing happened, cut out, dealt with, and that's the right thing. But in this instance, we haven't got any signal or anyone who can convince that there's something behind the scenes that we should worry about.
Okay, the next question is quite a deep one, and goes to the very central issue of trust, or the lack thereof, and perhaps chickens coming home to roost with respect to things that have happened in the past, people being underserved in the local health economy. And I'll just read it out. It says, the panel continuously say to refer to government's information websites. However, in the past, the British government's racist history with the BME communities in the past, and more recently with their hostile environment immigration legislation, may, especially to the elderly, lead to them refusing to have the vaccines because they do not feel the government's information about the vaccine can be trusted. How would the panel address and advise about this issue? And I think this is kind of underlined by research that's been released, which suggests that the uptake of the vaccine amongst BAME peoples within Britain is likely to be less because people have less of a trust of the state, as it were, as opposed to other category groups. So how do we deal with this issue of lack of trust in the state, where people feel that they've been disserved or ill-served by what's happened in the past, and now that it comes to vaccine time, the kind of call is for BME people to be at the front of the queue. Dr. Tosin, I mean, obviously, you're the youngest of all of us on the panel, but in terms of kind of what people are saying and the lack of trust, how do we navigate that issue?
I think the lack of trust is completely understandable, especially, you know, with the disparities that we've seen in the deaths with COVID, or even maternal mortality rates that we're hearing being talked about. And these things are multifactorial. So they're complex issues, but I think the lack of trust is definitely founded and is definitely heard. I think in this particular circumstance, when it comes to COVID, we have to realize that, you know, Black people are more than 4 times more likely to die from the virus when compared to their white counterparts. So I think with the knowledge and the information we have to weigh these things up. And this is a pandemic, so it's not just affecting certain people in the community. So I think with that knowledge, I think we know that the government and the world are trying to get rid of this virus. And it's not something that they're not giving different types of viruses to different types of people. So I think when it comes to the virus, I don't think we should necessarily be fearful in terms when it comes to race, but I completely understand the mistrust. And I do think the government and Public Health England are waking up to the disparities. And, you know, some people say too little, too late, but it's never too late. And I do see work being done, and I do see more conversations about the issues, definitely more recently in this past year. So I think having these conversations and speaking about the mistrust is important, because we can only see change if the conversations are being had. But I don't think that should stop us from essentially helping ourselves and helping people around us in terms of this virus and protecting our health and protecting others.
Thank you very much. There's a question at the bottom here, and I think it's been answered partially before, but I'll go back again. Why are BME people more likely to die from this virus? I'll take that, Dr. Ifeanyi. Why is it that BME people seem to be more exposed or more vulnerable to this particular virus?
Okay, thanks. I'll take that and I'll add something to the trust issue as well. I don't think anyone fully understands the one particular reason why people of different ethnicity that are not Caucasians are more likely to die. In my presentation, I did allude to some factors that may seem to be the main factors. One is the underlying health condition. So for example, the diabetes, hypertension, we know is more prevalent in people of Black and ethnic minorities. The other thing is occupation, and social deprivation, which is where the racial inequality exists. And one of the really contrasting issue with this vaccine is that if the vaccination is not universal, the disparity that we already see, the inequality that we already see, deepens even more. Because when you have a group that is at higher risk of contracting the disease because of their health condition and because of also the type of jobs they do. So driving the buses, working in hospitals, working in care homes, social care. So those front line facing occupations that you're more likely to come in contact with people. Remember I said the virus follows people. Then you're more likely to get this disease. And then if you have underlying health condition, there's more likelihood to die. So those things packed together, and then the trust issue comes in and then stops people from receiving the vaccine. Obviously, the disparity goes even further. And then you're more likely to be in a job that either you have to go to work. If you're not going to work in the office, you have to go to work to do your job. And to self-isolate is a big issue. So all those compounded issues then create a very, storm that, the perfect storm for BME, in terms of higher risk. Now, these are speculation based on other things. So I think the jury is still out in terms of trying to understand why. There were theories that people were bashing around vitamin D, and my brother has spoken about this before. But there are the government have actually commissioned 3 studies trying to look and understand this. And I'm sure in time we'll be able to understand that. Now, the trust issue, just very quickly, it's interesting that across the pond, the other side of the pond, America, that the issue is that people are crying that the vaccine is not being offered to people of ethnicity in the other way around. So their issue, their race issue, obviously racism anywhere is racism. So their issue is about how it's offered. Our situation is that the vaccine is universally offered, but the uptake is less in certain ethnicities. And that's why we are kind of, being part of this conversation. One of the things about trust is if you feel that you're not represented in the decision making, in the research, in the conversation about certain things, you feel alienated about it. But one of the things, and Tosin mentioned that the conversation is ongoing now. You see more diverse ethnicity talking in PHE, in other aspects, talking about COVID. And I think it's helping in my own, where I work, in the hospital where I work, the uptake was quite low, but there was a big conversation involving people of ethnic origin. And the conversation has helped a lot of people understand there is no conspiracy against a particular race in this vaccine. When I was training, I had to do vaccine trials, and for me, it was quite a good opportunity to be there recruiting children of white, black, whatever ethnicity into vaccine trial. The difficulty is that we have not been part of this bigger conversation in the past enough, even when the trials were being done. So we need to be seen to be part of it. And one of the things is not because we don't want to, it has been the way the system operates. And this conversation is ongoing, and we can only do that by being there and not alienating ourselves. If we did that for this particular thing, the inequality would deepen. And that's the fear.
Excellent. Thank you for that. So really, we need to engage the system to change the system. And the more operatives we have like yourself in these medical systems, then the better for us, better for all of us, because the quality of the general health will improve. Next question. Is the vaccine actually a vaccine in the sense that it does it provide immunity and protection from infection, or is its main objective to suppress the symptoms and morbidity related to aspects of the virus if one becomes infected? So I'm gonna who's gonna go? I think Dr. Ifeanyi again, because of your experience with vaccines themselves. Is it actually a vaccine?
Yes. Yes, it's a simple answer. It's a good question, but it is a vaccine. I mean, the three we have are vaccines. And now, can I just clarify what vaccines do? Vaccines do two things. So one, the vaccines train our body to produce antibodies and stop infection. That's one thing. And the other thing vaccine can do is vaccine can train our body to stop disease. So infection and disease are two different things. So infection is you could come in contact with COVID, have the infection, have no symptoms, don't pass it on. And the other one is you get the infection and then you have the disease, which will be mild, moderate, severe, it could be. So the vaccine are built to do that. What we don't know yet is whether the vaccine stops acquisition of infection. So we don't know that yet. The data is still ongoing, but we know that it stops severe disease. And that's how the license was given, because it stops the disease that is severe and mild and moderate. And that's the one that we're bringing people into hospital, and some sadly succumb to it. So yes, vaccines, and we have the potential to do those two things I mentioned.
Okay, Dr. Peter, here's one for you. I heard you say that the viruses given to people from BME backgrounds are the same as those given to our white counterparts, but I'm not sure that our DNA is distinctly different. So is it possible that the vaccine could give side effects to one group of people and not the other? So is there a difference in...
There's no, I mean, it's the same vaccine being given for every ethnicity group. And so far, I mean, I think it's been given in America and here and other places in the world. It doesn't seem to show that it's having any impact on people of other ethnic groups. So I don't know where that information is coming from.
Okay, cool. Well, circling back to an answer you gave previously, so thank you for answering my questions, Dr. Ifeanyi and Dr. Peter. Peter, if I understand your response correctly, my hypertension and asthma is controlled by medication. Does this mean I'm not a high risk, cannot receive the vaccine now with people age 65 and over? I am under 55.
Okay. I think the only way, if you want to get, is to talk to your doctor, because what has been happening now is that with the information of the grading which has come from NHS England, I'm sure if your blood pressure is controlled and your asthma is controlled, you might be probably in group 5, most likely, considering your age. And the only way, if you're concerned, is to speak to your GP, because what's happening is that some vaccines are being brought to the GP at a later stage, maybe Thursday, Fridays, when because when they remove the vaccine from out of the fridge, it has to be used within a certain period. And during Thursdays and Fridays, they pass it on to GP surgeries, to the AstraZeneca one, to be given out. So lists are compiled. So probably if you're eager to have it done, speak to your GP. They could upgrade you, put you on the list, and be called to have it at a later stage. I mean, people are doing that. But if you want to follow the grading given by the government, and unfortunately, you have to wait your turn.
Okay. This is a question about the frequency of the vaccines. I'm quite worried we have to wait 12 weeks, I think they mean, as opposed to 3 weeks for the second jab. What are your thoughts on this? And I will give that to Tosin.
Yes, so you're right. In the UK, they've extended the time between the first vaccine and the second vaccine to 12 weeks. And their reasoning behind this is because they feel that it's more beneficial to protect as many people as possible than just a few people. You can get as many people as possible vaccinated with the first dose, that's creating a larger amount of protection. More people have protection against the virus. And they feel that most of the efficacy, so the protection, actually comes from the first dose. And actually the second dose is important, but they feel maybe it's more important in the duration. So everyone will still get a second dose, it's just about when. So the theory behind it is that we get the vaccine out to as many people as possible to protect as many people as possible.
So it's a tactical thing as opposed to a clinical thing? Is that
from my point of view, Dr.
Yeah, okay. Well, I think that there's a tactical aspect of it, but I think some information was released last week about a study that has been done by AstraZeneca. Apparently, some people were given a dose which was smaller in quantity, and that cohort apparently had a second dose 12 weeks after. And when they assessed their immunity, the antibody level compared to those who had it in 3 weeks, that was far much better. So apparently, WHO actually is pushing for that they might probably extend it to 12 weeks and over.
Excellent, excellent. Dr. Ifeanyi, you wanted to say something?
Yeah, no, I was just going to say, whilst it's very tactical and very pro public health, which is why the UK government, they were wanting what Tosin said, absolutely smashed, and that's the truth. They wanted to give it to more people. But the evidence emerged. Obviously, they didn't know what's going to happen at the end. The science showed that this is possible. We know that there's actually one vaccine, Janssen, their vaccine will be just one dose, one shot, and one shot only. So based on that principle, and the data from the AstraZeneca data showed that some of the participants, their vaccine were spaced out and the protection was still there. We're now having clinical data. When I say that vaccines are as good as when you roll them out, the data is actually coming in. Clinical data from using it is showing that there is a protection up to 2/3 in the first 3 weeks of receiving the vaccine. So they have not published it yet, but the sounding is that this will be published soon to confirm that what the UK have done is right. And WHO, like Peter mentioned also, is now kind of, initially there was a bit of noise about this, which is right to question the science. But I think they've been vindicated by showing that this is actually a very good move that they have done, and more people are protected at once.
Dr. Ifeanyi, there's another question about, are not the vaccines actually gene therapy experimental vaccines, with the emphasis being experimental? So are not the vaccines gene therapy experimental vaccines?
No,
does that make sense as a question?
Well, so this is not a gene therapy. So
Okay.
because I explained that the mRNA goes into the body, sends the signal, say produce this spike protein. If you see, corona is like a crown, so the spike protein. So all it does is goes into, it says produce these proteins, and then whatever they send to your body is coated in a fat particle, disappears and destroyed. The mRNA is destroyed. It does not alter your gene. It does not go into your cell to do anything. All it does is then tells your, Peter mentioned your T cells. So the T cells are the ones that do the memory. They store it in the memory and say, I have seen this virus, because the protein is what gives it the identity. So one, it is not a gene therapy. It is a vaccine.
Okay.
I don't know what the rest of the question was,
Okay,
but
cool, yeah, okay.
on both accounts, it's a vaccine.
Okay, we're coming to the end of our question session here, and I reviewing the ones which are left on the Q&A function. Hang on, there might be another one that just come up, but one of them is, does the use of garlic, ginger, lemon, menthol, zinc, or preferably boiled in water, help as a prevention or cure to COVID? And I'm going to drop that one on Dr. Tosin.
No, essentially. There's been no evidence. I mean, obviously, living a healthy lifestyle is good, and it sets you up better to handle any viruses or diseases coming at you. But that particular combination and that you may hear or miracle, there's just no evidence for them. So I wouldn't lean on them as forms of protection at all.
Okay, I'll round up with this last one. Why is it that vaccines cannot provide 100% protection? If I take the vaccine, there's still a fear that I may not be protected. And I will send that out to Dr. Peter.
Yes, I think the percentage we do have, for example, if you take the flu, the efficacy is around somewhere between 50 and 60. The fact that you're not fully immune means that you can't get the infection, okay? However, you have enough immunity not to cause a severe illness. Are you getting it? So it's not that you can't contact that. You can have contact the virus. However, you have an immunity that can fight the virus such that you would not have a severe illness. So you might probably have a mild illness or even not have any symptoms at all. So that is how the efficacy is coming in.
Okay.
So they wouldn't make it 100%.
Well, I think we've traversed a wide range of questions, and it's important for us to have authenticity when it comes to kind of the skeptical issues that we have pertaining to taking medicine, because actually we're all being asked to put something into our bodies. But I think we should do in faith. I think I remember once somebody preaching at New Life saying that sometimes you need faith to take medicine. And that's true. That's a truism. But we shouldn't, as Christians, live in fear, because that's not our portion as Christians, to live in fear. We live with power, love, and soundness of mind, and that should be like our calling card when it comes to making decisions. Before we go, is there anything you want to say in closing, as professionals, but more importantly as Christians who are kind of like fighting at the coalface of this I should say pandemic? But is there anything you want to leave us with, Peter?
Yeah, I would say that probably you might not have made up your mind today, but it's a decision you should take. We are available, but your health professional is also available to answer your questions. And you should not be shy asking questions. As you said, this is a big decision you want to take. And if you have any doubt, yes, it's good to have doubt. It's good to have questions. However, don't keep your questions and doubts to yourself. There are venues that you could share that doubt, and you'll be given good information for you to make an informed decision. This is not mandatory. You have to make the choice, and I will advise that you have that peace of mind, such that you know that whatever decision you take, you are not judged by it. No one judges you, and you are confident in your decision, and you enjoy the peace of the Lord.
Dr. Ifeanyi?
Well,
Oops. Something might have happened technically. You might come back to him.
it's really good that the church loves and cares. Am I?
Yeah, you're right. You just faded out for a bit.
Okay. The information is being provided to our brothers and our sisters, and some of us are involved in the science, and this is God-given wisdom to so many fantastic people, and some of us are tapping into that. I believe in the science, and I believe in miracle of healing, but I also believe that if there is a situation and there are remedies that can be used, and vaccine is a way of protecting people from this severe disease that has caused a lot of heartache. I've seen it in my own practice, but I also heard and seen people who are bereaved from the side. And we can only encourage our brethren to think about it. I've received the vaccine myself, and I'm willing to share my experience. And the best thing we do is, if you have pertinent questions unanswered, ask through the elders or approach any of us. We'll be happy to address any particular issue. But the key thing is you're making a decision based on a very informed information, that it's not based on any, I have no personal gain for the companies or for the vaccine. My gain is that my brothers and my sisters are safe. By the way, I was a member of the church for many years and I live in Derby, but look at what COVID has done. I'm linking up with this church in Derby today, and that's what we've been doing since the pandemic. So there are some positives from this, but I pray for you all to think carefully about the decision you make, and God will surely bring us back and heal our land. Thank you.
Amen. Tosin, please, any final reflections or thoughts?
I would say that this is a difficult time, and I think we are all going through some form of difficulty or have experienced some form of difficulty or hurdle or obstacle that we've had to overcome in this time. And I think in that, just remember that you're not alone. Lean on those around you, lean on your family, your friends, your church community. That's what your church is there for. They're your extended family. So just remember that you're not alone and there is support out there.
Thank you very much. I'd just like to extend a real thank you to all of you for taking the time and effort to put together this event. We as elders or oversight are appreciative of your sacrifice of time. We just thank you and bless you. I also like to extend thanks to James Beat, obviously, Chaz Woods, Boma, Mark Russell, people who've been in the background who've helped pull this event together. And I'd just like to leave you with one word of encouragement. Do not be anxious about anything, but in everything by prayer and supplication, with thanksgiving, let your requests be made known to God. And the peace of God, which surpasses all understanding, will guard your hearts and your minds in Christ Jesus. I pray that the peace of God be your portion in the midst of all the tribulation that we're going through. That peace of God will hold you up. That peace of God will assure you. Make decisions based on wisdom, don't move in fear or foolishness, but faith. Faith pleases God. So walk by faith, my brothers and sisters, and have a lovely rest of the remains of Valentine's Day, and a lovely week going forward. So bless you all in Jesus' name. Thank you very much.
Thank you.
Take care.
Thank
Bye-bye.
you.
Bye for now.
Bye now.
Bye-bye.